David Fox. I'm a physician in maternal fetal medicine here at Ohio Health. I'm the medical director of Ohio Health Maternal Fetal Medicine. Most of what we do is outpatient medicine, where we see women who are pregnant, who have special concerns. Usually they require an ultrasound so we can look at their fetus, their unborn baby, and see if there's any abnormalities. We check the growth, and we check other things as well. We also do a lot of consultations. Pregnant women have a lot of questions about their pregnancies, particularly if they have some type of medical condition that makes them high risk. And we do some fetal monitoring here. And then another part of our practice is we actually go in the hospital and see women who are hospitalized during their pregnancies for a whole variety of reasons. Pregnancy, even in the best of situations, entails certain kinds of risks. Women can develop high blood pressure who were previously healthy. Women can develop diabetes who were previously healthy. And so any pregnancy has the potential to have additional risks that come about during the pregnancy itself. But there's some women who actually start out before their pregnancy with special medical conditions, for example, that increase the risk of pregnancy to either them or to the fetus or to both. For example, some women have twins or triplets or even quadruplets, and they can have a high risk of going into preterm labor or breaking their water early or having high blood pressure. And some of those conditions can entail that they deliver premature babies or that they have to be hospitalized and given special medications to prepare them for possible delivery. There are also fetal conditions that make somebody high risk. Some women come in who are completely healthy, but we identify that their unborn baby has birth defects or a birth defect that requires special monitoring during pregnancy and potentially extra testing. So high risk can mean a lot of things. It could be women who have diabetes when they get pregnant, women who have high blood pressure when they get pregnant, or women who develop problems while they're pregnant that they didn't have prior to that. That's a really excellent question, and the answer to that is not entirely known. But we do know, for example, with gestational diabetes, that the women who get it are women who oftentimes are predisposed to diabetes even when they're not pregnant. And then when they become pregnant, their placenta, which only exists during a pregnancy, makes certain hormones. It causes their bodies to be resistant to their natural insulin. And when that happens, that insulin resistance, it makes their blood sugar go up. And that high blood sugar can have implications, potentially negative implications, for the well-being of their unborn baby, not just during the pregnancy, but actually for the rest of the baby's life. And so just having a placenta actually plants the seeds for developing gestational diabetes. And likewise, for high blood pressure in pregnancy, although some women come into pregnancy with high blood pressure, many women develop it anew during pregnancy, really for the same reason. There's something going on with the placenta, having something to do with the placenta not invading the uterus as it's supposed to, that leads some factors to be released that cause them to develop high blood pressure. And then, once they deliver, either suddenly or over a period of days or weeks, their blood pressure will go back to normal because the placenta is no longer there and they're no longer in that pregnant state. What I would say to that is it depends on what you're protecting them from. Some of the protections from being a high-risk pregnancy occur before they even become pregnant. For example, there's a condition called spina bifida, which is a form of what we call open neural tube defect, and that occurs very early in pregnancy, shortly after conception. And the way to reduce the risk of that happening is to take a vitamin called folic acid before even pregnancy occurs, so that the folic acid levels can do their job to prevent that birth defect from happening at all. Likewise, women who have pre-existing diabetes are much better off having their blood sugars under excellent control before they even become pregnant, because it markedly reduces the risk of birth defects as well as the risk of miscarriage. So even before pregnancy, some of these things can occur. And then there's routine prenatal care where women make sure they see their doctors or their nurse practitioners or their midwives regularly so that they can be monitored for their blood work, for fetal heart rate, for the growth and the weight gain of the pregnancy, as well as other important screening tests that they're offered. So there's a whole lot of things that can be done that differentiate good prenatal care from poor prenatal care, from no prenatal care, that we believe improve pregnancy outcomes dramatically. Tremendous medical advances. One of the most important medical advances came about from a pediatrician in New Zealand who published a paper in the early 1970s showing that if you give a pregnant woman steroid shots prior to delivery of a preterm baby, that it markedly reduces the severity of breathing problems, the incidence of breathing problems, lowers the risk of death, being on a ventilator, and in some cases, in severe prematurity, it actually lowers the risk of bleeding in the brain due to prematurity. That was an enormous contribution that unfortunately did not get applied in medicine widely for about 20 years until doctors finally came to realize that this is a real important thing to do. So that's been enormous. On the pediatric side, for the neonatologists who take care of babies, there's there's a chemical called surfactant that replaces the surfactant in the lungs, and it allows babies who have immature lungs to expand their lungs easier and makes them able to breathe better. So that, in combination with the steroids, is one example of a huge development in perinatal medicine. A case that that was particularly memorable for me is having a fetus that was on the verge of death from an infection called parvovirus. Parvovirus is something that little kids bring home from school or daycare, and adults can get it, but when pregnant women get it, it can actually, in some cases, lead to their fetuses developing it, and they can die, usually due to severe anemia. And so I actually did a fetal blood transfusion on that case by placing a needle into the umbilical cord while it was still inside its mother's womb and giving it blood so that it could survive the infection. And then the baby's now a normal, healthy kid. He's probably about 12 years old now. I think fetal blood transfusions are something that we do in our practice as a very life-saving thing that we do for a variety of reasons. For fetuses that otherwise would not survive to birth, we're able to keep their blood count high enough so that they can continue to mature until they're ready to be delivered. It's very important to have compassion for people who are going through this, because you can't imagine what families must be going through when they find out, for example, that their baby's going to have a birth defect when it's born, or that it's going to be premature, or they're not sure if it's going to survive or not. And so it's very important to have compassion, to recognize that the way people deal with that information is very, very varied. And so you just have to be there for that family and to try your best to listen and to be with them and to be present with them and to try to meet their needs as best you can. And at the same time, we all have feelings, and we all feel the pain of a patient, and that can be difficult as well. But we also have to remain professional and do our job, and realize it's not about us and what we're feeling, but it's really about them.